We are a little late. So, our last session, in principle, it is a logical continuation of the previous session because the patient-centered approach is the thing that includes a lot of various components, including patient training, patient education, provision of what you call enablers. So this is what helps the patients to obtain such treatment, and quite naturally that's treatment of comorbidities. So I suggest that we start our last session with a video from Armenia. This is the story of the patient that is being treated from MDR-TB using new drugs, and at the same time
Հակոբյան Անդրանիկ 58 տարեկան ապրում եմ այստեղ։ Հենականի ծնված եմ։ Ես տեղակայուն եմ, դրա համար իմիպենեմ եմ ստանում սիստեմա։ Առավոտ մեկ իրիգուն եմ։ Եղավ ուժը 16 месяц։ Դեոր տուբերկուլոզը բուժում են, դրա հետ մեկտեղ խսիրներ են նայում, լիարտը լուբոյ բոլոր օրգանները նայում են, հետազոտում են։ Հետազոտելու ժամանակ զգացին, որ լիարտը հեպատիտ C ունեմ։
We know that some TB drugs had negative impact on the liver, and the same thing we can say about hepatitis C virus. We had patients for whom we had to stop TB treatment because of liver toxicity of TB drugs.
Ամեն օր ժամինին խմում էի, ամեն օր պատրիատ։ Աստղաձև, մեկը աստղաձև է, մեկն է ավալնի։ Ասեցին, որ 90 օր է, ինչ դենց։
The patients who receive hepatitis C treatment in combination with TB treatment are examined and followed up, but till this moment we haven't found any serious problem with this.
Ուսաղորն է աշխատում եմ, այդքան տեղերը խմում եմ, տենում ես։ Ես պարապ չեմ կարան աստեմ։ Դե տան վրա է ահագին փտած տներ է սաղ։ Միշտ գործը կա։ Ես միշտ սաղորը շարժման մեջ եմ։ Դե չի կարելի պրեմիժուտ տալ էլի, տեղերը բարդաճանան ծևով խմեն, ես էլ խմում եմ։
The likelihood that this patient will be classified as cured in the future is very high, and we hope that his hepatitis C is cured and we will not have any factor which will disturb us to continue his TB treatment.
Որ կյանքերս երկարն ա էլի ազիջան։ Գիտենք որ էլ հիվան եթե բուժվենք, Կյանքը շարունակվում է։
А сейчас доктор Аганна Киракосян поделится с опытом армянской программы по ведению пациентов с гепатитом С и туберкулезом с множественной лекарственной устойчивостью.
Thank you very much for kind introduction and also possibility to give this speech today here. So I'm going to talk about hepatitis C screening and treatment among drug-resistant TB patients in Armenia. Hepatotoxicity is common during multi-drug-resistant TB treatment. Hepatitis C associated with increased toxicity. Previously, treatment of hepatitis C was not possible in patients with active TB. New treatments for hepatitis C with direct-acting antivirals may be given during TB treatment. That's why it is very important to identify patients with hepatitis C disease who may benefit from this treatment. Objective of this screening was to assess the prevalence of hepatitis C in MDR-TB patients in Armenia with a view of introduction of direct-acting antiviral as required. Armenia is a landlocked country with a high MDR-TB burden. MSF started to support MDR-TB treatment since 2005. But hepatitis C testing was not done systematically in 2005, 2015. This was done only for patients with high risk hepatotoxicity, and this covers only 6% per year. Methods that we used for screening. So target population for screening was chosen all the patients receiving conventional MDR-TB treatment with or without new drugs. And HCV testing algorithm includes HCV serology testing, and once hepatitis C antibody testing is positive, we perform PCR testing and genotyping, and then we do also fibroscan. These are the results of the screening that we did. So of 208 patients screened, 62, which is 29.8%, were HCV antibody positive. Of them, 58, which is 93.5%, were tested with PCR, and 40, which is 69%, were PCR positive. So overall, we find out that of these 208 patients, 40 had active hepatitis C disease, which is almost 19%. The predominant hepatitis C genotypes were 3A in 19, which is 47.5%, and 1B in 14 patients, which is 35%. And the details of the rest that make up a little 17, these were genotypes 2 and 1A. A significantly higher proportion of positive hepatitis C serology was found in a univariate analysis in patients, in the males, patients aged over 35 years, previous prisoners, co-infected with HIV, and also who had extensively drug-resistant TB. How we started TB treatment. Priority was given to the patients who had hepatotoxicity, who had developed hepatotoxicity during MDR-TB treatment, to the patients who had genotype 3 as a high risk to develop disease, to progress disease quickly, and to HIV patients once viral load is undetectable, and to the patients with F3, F4 stage of fibrosis. And inclusion criteria includes pregnancy, detectable HIV viral load, age below 18, and also advanced terminal diseases. So these are the results of treatment. We enrolled the first patient. You have already seen the video. This was our first patient enrolled into the program in December 2016. And since that time, until January, end of January 2018, during 14 months, we enrolled 26 patients. So the cases where DAA fully overlapped MDR-TB treatment were 15, which is 58%, and the rest, which is 42, we introduced DAAs after MDR-TB treatment. Among this cohort, number of cases with MDR and new TB drugs were 62% or 16, and the rest, which is 38%, received MDR-TB without new molecules. This is the characteristics of the cohort treated with DAAs. So you can see that majority of all the cases had genotype 3, which is 69%. And also in the next table, you can see that fibroscan test results showed that 58% were the first stage of developing fibrosis. They had F0, F1 like result. And people with F3 and F4, the sum of these numbers is 34%, so they had advanced fibrosis, and as I already told, this was a priority to start treatment for them. And the vast majority of patients were HIV negative. You can see that it was 86%. We used to have 3 types of treatment regimens. Usually this is from 12 weeks to 24 weeks, depending on the stage of fibrosis. And we had regimens sofosbuvir plus daclatasvir or sofosbuvir with ledsipasvir, and also sofosbuvir, daclatasvir, and ribavirin for the patients with advanced fibrosis in the stage of F3, F4. And just to say that DAAs are only tablets. We don't have any injectable. Patients should take the drugs once per day if it is regimen only with DAAs. And in case this includes ribavirin, in this case, ribavirin is given 2 times per day, and it is weight-based one. Sofosbuvir is 400 milligram tablet, and daclatasvir is 30 or 60 milligram tablets, and the dosage of daclatasvir varies depending on the concomitant therapy that patient is taking, because some drugs can increase or decrease level of daclatasvir in the plasma. So these are the results, outcomes of treatment with DAAs. Again, this is description of these 26 patients treated. By the January 2018, there have been 23 patients who were eligible for PCR at the end of treatment. I would like to mention that how we analyze outcome of hepatitis C treatment. We do viral load at the end of the treatment, and then 12 weeks after ending the treatment. And this we call sustained virological response. So number of people eligible for PCR at the end of treatment was 23, and among them 4 have been positive at the end of the treatment, 17 were negative, and for 2 we couldn't perform viral load test because due to technical problems. By the end of January 2018, eligible for SVR12, number of people eligible for SVR12 were 13, and viral load showed that it was positive for 1 patient, this was negative for 10, and for 2 we couldn't perform because they left the country immediately after completing DAA's treatment. So we were not able to test these patients. I would like to mention that, of course, it's not a concern when the patient is positive at the end of the treatment. We don't take any action, just we wait and retest it again after 12 weeks. So to conclude, I would like to say that high proportion of MDR-TB patients in this cohort had hepatitis C. Testing for active hepatitis C should be systematically performed at baseline on all patients with MDR-TB from regions with high prevalence of hepatitis C. Treatment for hepatitis C should be considered in patients unable to tolerate MDR-TB treatment due to hepatotoxicity or high risk of cirrhosis. DAAs are compatible with MDR-TB treatment, and preliminary results showed good tolerability and results. For future perspectives and challenges, I would like to highlight that it is very important to screen to do hepatitis C screening for all TB cases and not only MDR-TB. Hepatitis C treatment should be considered for all TB cases and not only for MDR-TB during TB treatment if hepatitis C treatment is a priority, and after TB treatment if the regimen contains rifampicin. This is because daclatasvir is contraindicated with rifampicin, and sofosbuvir and ribavirin are not recommended to use together. Concomitant use is not recommended. very important to address the problem, address availability and access to TAAs in all the countries, which means to lobby price and registration. And of course, the most important, I think, to develop a simple and affordable patient-centered model of care for hepatitis C treatment in TB patients, which will include support for alcohol and drug addiction. And with support, it is very important because with this we will address all other risk factors, like if we will support with alcohol, we will reduce liver damage, and if we will support, they will stop IV drug use. With this, we will stop reinfection. And my acknowledgements goes to Armenian National TB Control Center, to Director Armen Hayrapetyan, medical staff, patients, to MSF Armenia, MSF France, and Epicenter, and of course to you for your kind attention. Thank you.
Dear colleagues, following the tradition of today, my suggestion is to collect the questions at the end of the session, if you do not mind. So, hepatitis C, indeed, it may have a significant impact on the course of treatment, but at the same time, diabetes is a risk factor. It is a risk factor for tuberculosis. It is a risk factor for MDR-TB. Dr. J. Achar is going to present the experience of the program in Chechnya on the joint management of patients with MDR-TB and diabetes.
Thank you, Alex. I just wanted to start by thanking the organisers for letting us talk about diabetes and TB. It's a topic that I think rarely gets discussed at TB conferences or TB meetings. Well, it's not co-infection, it's comorbidity of diabetes. I'm also fortunate enough to be able to present some of our preliminary data from our collaborative project in the Chechen Republic. TB prevalence and incidence we know is higher amongst patients with diabetes. This is quite clearly understood. We think that we can identify those that are highest risk by the severity of their diabetic disease, so those predominantly that require insulin. We believe that diabetes prevalence is also higher amongst patients with TB when we screen them in our clinics. So the effect of diabetes on infectious diseases is well recognised with other infections. And so, to be honest, this is not a new concept for infectious diseases specialists. So diabetes prevalence at the moment, on the graph on the left, the map on the left, highlights that the presence of diabetes is not uniform across the world. Predominantly affects North America, some parts of Europe and some parts of Asia, and the Russian Federation there. I think key to this topic of the comorbidity of diabetes and TB is that the incidence of diabetes is increasing, along with an ageing population, and in general across the world, a population that's gaining weight. I think that the topic of diabetes and TB is an important one to consider as we go forwards trying to eliminate TB. So it's projected to increase by about 13% in the next 20 or so years. Various modelling studies have suggested that the impact of diabetes is going to increase on TB, and it could negatively impact the fight against TB by around 8%. The idea is that a strong reduction in TB needs to address the comorbidity of diabetes amongst the patients we treat. And in fact, the WHO in their NTB strategy specifically highlights diabetes care, and the impact of non-communicable diseases is explained quite clearly in the SDGs. So we know diabetes is a risk factor for TB disease. It's estimated that around 15% of current TB disease is attributable in some way to diabetes. And it's associated with many different stages in the TB cascade, from from the transition from infection, so latent TB, to people with active disease. We know that people with diabetes have worse TB outcomes, so the end of treatment outcomes. We know that people with diabetes also have an increased risk of death, and we believe that people with diabetes have an increased risk of relapse after treatment. We think that, although we don't know so well, so the data is not quite so strong, but we think that control of diabetes, and rational thinking would make you think this, control of diabetes will improve treatment outcomes. TB tends to worsen glycemic control, so it actually makes the control of diabetes more difficult, similar to most other infections when patients are diabetic. And we believe that, and logically, we think that people with diabetes may have more toxicity to some of the drugs that we use for TB, such as the neuropathy so the nerve problems we associate with linezolid, and the renal problems we have with some of the injectable drugs. So just switching to the Chechen Republic in the Russian Federation, I might skip one slide. Yeah, so there was a collaboration between MSF and the Chechen Republic for many years. In early 2015, there was this decision to investigate and to try and manage the comorbidities of diabetes and TB together. During that time, so from early 2015 until fairly recently, the management was collaborative in its approach. So we tried to engage with the endocrinologists that historically have treated diabetes in the Chechen Republic. We funded one endocrinologist working for MSF, and we used the screening process for diabetes amongst our TB patients to enroll them into a group that had that were given more close attention. We used kind of regular follow-up, similar to any outpatient clinic, to address glycemic control, so measuring blood sugars, cardiovascular risk factors, and other complications of diabetes. So just to go back one slide, so the Chechen Republic is in the southwest corner of the Russian Federation, those don't know. Similar to the rest of the region, TB incidence has been dropping over the last 5 to 7 years, but still it has a very high rate of second-line drug resistance. So local data suggests that around 14-15% of all MDR-TB cases have additional resistance to fluoroquinolones and second-line injectables, while a further 10% only have fluoroquinolone resistance. So the cohort that I'm going to very briefly describe is around 95 patients split across those drug susceptibility categories. So the vast majority here are drug susceptible TB patients with smaller proportions of MDR and pre-XDR and XDR TB. As you might expect, most of the patients are older adults with type 2 diabetes, so those diagnosed in later life. So just to give you there's two columns there. I've put a comparison group, not as any scientific process, and not from Chechnya, but from another program that I support, just to give you an idea of what a normal cohort might look like. So the age in this cohort was 58, and in another regional cohort that I support, the average age was 32. So this cohort was significantly older than a normal, I would say, TB cohort from this region. We had a similar kind of gender split, maybe slightly more women in our TB cohort, but also you'll notice that the BMI was significantly higher. Obviously, being overweight is a risk factor for type 2 diabetes. The HbA1c, so a measure of the level of control of diabetes, was 9.7, which is higher than most recommendations would suggest. A target HbA1c would be below 6.5 or 7. And the systolic blood pressure, also an important part of cardiovascular risk, was also higher than recommended. Just on the right there, two graphs very briefly kind of outlining the BMI at the top per DST group, which was broadly similar, and on the bottom there, the HbA1c across groups, which suggests possibly that patients with XDR-TB had better control of their diabetes. So the results, this is very preliminary data. We're still looking at outcome data, which we're getting from the National TB Programme. But we had a very low rate of loss to follow-up amongst these patients. So only 7 patients were lost to follow-up. But we also saw 9 deaths in a cohort that was predominantly drug-susceptible TB, which is quite high. We noticed a change in HbA1c, we managed to reduce the HbA1c within these patients down by just over a half, which I think is a useful result. But we did notice that the BMIs increased, which obviously is a sign of improvement in TB, but also potentially could negatively affect the diabetic control. So I guess the reason I put this up is to highlight the challenge for endocrinologists managing diabetic patients who are on TB treatment. So as their TB improves, their weight increases, which can make their diabetic control more difficult. On the bottom, on the bottom right there, I highlight the graph of an average of creatinine amongst our patients and their follow-up. And really, the purple line stands out there, which shows an increase in creatinine amongst our XDR patients, acknowledging that the numbers that we're talking about here are quite small. So from this limited data, I can say that it looks like diabetic TB patients are older, at least the ones that come to our clinic and are diagnosed with TB. We must acknowledge that there might be diabetic patients that never come to our clinic. So young children, for example, might be diagnosed with type 1 diabetes and succumb from TB before they're diagnosed. So those with DSTB, at least again from this very small data set, they may have worse glycemic control. We believe that co-management of diabetes and TB in one clinic can improve HbA1c, so this measure of diabetic management. We saw a very slight worse renal deterioration with increasing resistance, which may not be a surprise given that we use the injectables often for longer in people with XDR-TB. But also we noticed that diabetic patients have a lower loss to follow-up. There's still lots more work with this data to look at TB treatment outcomes and other interesting factors amongst this 100 or so patients. So just my slide, key messages. People with TB complicated by diabetes, I think they need special attention. The screening of TB patients for diabetes is really important because their outcomes can be quite different, but also their level of engagement with the clinic could be very different. We perceive that the level of knowledge of TB amongst the endocrinologists who are treating diabetes in the community was quite low. It's probably the same in my clinic at home, to be honest. And that actually that effort to teach them and to give them some tools to diagnose symptoms, to detect symptoms early might be very useful. Treatment of diabetes will hopefully, I should put hopefully in there, improve treatment outcomes. We've seen it in other parts of the world. We wouldn't expect any different from this region, and I'm hoping we might be able to show it from some of this data. I personally think that the risk of loss to follow-up is less amongst people who are engaged with another disease. So it's another potential tool that we could use to retain patients in treatment for TB treatment, because it's only a fixed duration. Just to acknowledge all the patients, our collaborators, the doctors and nurses in the Chechen Republic for their help with this.
Thank you, Jay. That was a very interesting presentation. We have seen patients with TB and diabetes. I think we all have seen them. They usually are quite difficult or hard patients, but they don't look like patients who are ready to die right now. Another group of patients which cannot wait at all is HIV and TB co-infection. Dr. Venera Barotova, a TB center, Tashkent. Thank you, dear colleagues. I would like to express gratitude to the organizers of the symposium, and also thanks for the symposium to all organizers. I would like to give you a very brief and short outlook of of work we are doing in our center on with MSF on integrating services of HIV and TB. This is quite a substantial amount of work, but I would like to mention the following. This activity is mostly done in Tashkent city. Our main objective is not to lose patients, whether HIV or TB patients. You know, if we take HIV infection, the person when diagnosed with HIV is his data recorded in the computer. The computer or database is within the registration center. Usually, it's nurses can entering this data. So persons first reveal the first time they turn to the nurse at the admission ward, and the nurse distribute them for. Refers them to specific specialists. So nurse usually, first of all, send our patients to our doctor, who is a health practitioner, who is asking questions in accordance with the WHO questionnaire. So you see that on the slide. No or yes on question 1. If question yes goes to the first one, no to the first question goes to the other questions. So at some point, doctor will see that there are signs of TB with these particular patients. Then there is an algorithm for all other necessary activities to be taken. Again, the person is referred further, and the doctor asks this availability of those signs. Excuse me. Those features like cough, fever, and others. So sputum taken for gene expert, and chest X-ray is being conducted. After the genealogy X-ray study, gene expert, then the patient with this information then forwarded to TB dispensary, TB clinics. If all questions asked by a patient, the patient says no, there is no suspicion of current TB, it's a isoniazide prevention is then indicated. Prevention treatment. Okay, this is statistics on TB screening with gene expert. Since year 14, last quarter, we started this activity. So in the year 1, since only 1 quarter was the time, we only had 170 patients total. Out of 170, 20 patients were diagnosed with the TB Mycobacteria. Out of them, in 13 cases, these were rifampicin resistant, non-resistant or minus, and 7 cases are plus rifampicin. 703 patients took place in this in the observations in the year 15. 148 were diagnosed with TB Mycobacteria. About 22, 52, 22% of the total. So 84 rifampicin negative, 64 rifampicin positive. Year 16, as you see, and 17, accordingly, we had 731 and 773. And results seem to be quite relative similar to the previous year. And about 19% to 20% of patients indicate Mycobacteria with TB sensitive. So, medical services and HIV and TB co-infection in our center. First of all, screening research study have been taken place with 4,500 patients with out of 4,500 the number of for TB positive was found in 328, and negative results was 4,187. Out of 328 positive, 234 had started antiretroviral therapy, well, they were at antiretroviral therapy. They were sent to the TB hospital or TB dispensary, TB center for TB treatment. So, is 898 patients out of 4.2 thousand got isoniazid as prevention treatment. So, the patients turn to a center, and all necessary stages and studies are performed the same day. So when patient arrives to a center, he goes to the nurse, who then gives a referral. Some goes to infectionist specialist, then infectionist then forwards the patients, refers to the specialist for X-ray, and at the same time laboratory specialist to get a clinical lab. After that, the patient goes to the TB specialist. As soon as we started integrated work on TB and HIV, we have created the so-called TB specialist staff or group that will serve particularly our patients in our HIV center, so in the same facility, meaning that the TB specialists send a consultant, two consultants. These are consultants of our center, so that the patient will get through the joint consultation, will get assigned therapy anti-TB, and if he haven't been getting antiretrovirals for HIV, then he is assigned for antiretroviral therapy. If he's already on RVT, then there will be a certain adjustment of the course, and accordingly all the necessary therapy or TB plus HIV will be assigned and adjusted. So we have not the pharmacy, as we say, but actually it's a point where a medication can be given out to the patient. We have a therapeutic, so all necessary TB and HIV medication can be given out in the same place and in the center. So the vertical model is, you can see on the slide, things we have explained. We wanted to show you the scheme where the patient goes, a nurse, infections consultant, blood collection nurse. Why blood collection nurse? Many people who come to us must be checked for other, for our own, testing. We take CD4 count to check their immune system. We would take PCR to check number of copies of virus viral load, and then it goes to the clinical lab. If in case we reveal TB within the patient, and the patient is on the antiretroviral, so his result of CD4, viral load, and blood sampling, and we also make clinical examination. So we have a hematological analyzer that allows to check or examine the blood with 21 criteria. And these all results are delivered to the clinicist to get proper treatment prescription, and the pharmacist where to get all the pills and necessary medication as advised. TB dispensary or TB center. If you look previously, our patients, before we started this joint activity, coordinated activity of TB and HIV, we would we would usually accept the patient with HIV, then refer him to TB center, so that he will actually arrive to TB center, get checked for TB, and then with the results of the examination, he would come back to us. Now they don't have to go to TB center; they can get checked and advised in our center. I mean, we have a TB specialist in our HIV center. They get X-ray, all necessary other examination, and after that, the treatment can be prescribed. Of course, if the patient is revealed with active TB, she needs to get hospitalized, so we send it to proper inpatient facility. Inpatient facilities, it's where our patients receive both in pulmonology, National Research Center, and the First City TB Clinical Hospital. So there are two facilities for inpatient TB hospitals. So what we have achieved? First of all, diagnostic equipment. This joint work allowed us to organize properly to get a gene expert machine. We have X-ray machine. We do it all ourselves. Since, as my colleague have already mentioned, we also conduct treatment for hepatitis C. Fibro scanning is conducted, proper blood testing to define viral load for Hep C. We also work with the Scientific Research Institute of Virusology of the Ministry of Health of Uzbekistan. Ultraviolet lamps, well, this is to ensure proper infection control. Of course, they have a protected screen or lamp before installation. As everywhere, in every facility, we got help from a sanitary epidemic surveillance center. When radiologists came, took all the necessary testing for laboratory study, and after their permit, that to ensure there is a safety in place. So we have installed necessary equipment, and now during the day these ultra UV lamps are working. So TB specialists working in our HIV center. Previously we didn't have one, now we have one TB specialist in our staff. A laboratory staff trained to work with gene expert machine. So now we have a working staff, which is actually two doctors, specialists, and medium-level nurses trained. So generally, a level of awareness about TB in all HIV structures and services have been increased. The special brochure was distributed. So we develop a brochure and information materials and share them both among patients and among population in general for general awareness level increase. So TB-HIV communication form, a special form to be filled in, a higher proportion of diagnosed TB cases among HIV patients. Right after we started with this work, with all this partnership, we're trying to not to lose our patient, because quite often previously we would send our patient to TB dispensary to get this check. They might not get there because stigma and discrimination. That was something that was hindering our work, and this work here helped us to find newly diagnosed or newly revealed cases of the patients, and without going to the TB center. So we actually we have a database. In accordance with our plan, we do X-ray check examination twice a year, and in accordance with the plans and recommendations. Of course, with these achievements and improvements, we do have challenges, and I think everyone can have a problem of the triage of patients presenting with cough. When people come together and they're coughing, you have different type of cough, different type of patients, and how to sort them out is an issue. If a patient comes in and start coughing right in front of a nurse, he'll be noticed. But quite often they try to hide and try not to cough and be don't speak about that, and that's becoming an issue. Another reason patients try not to wear masks. We call it a surgical mask, the mask just on the face, but people avoid doing that. Another challenge is backup for digital X-ray equipment. So we are now working on them jointly. I think our problem can be addressed and will be addressed. So in order to organize proper conditions for work, you can look at the photograph of this is a TB specialist room. This is a X-ray machine facility, and this is just brand new made, and just wanted to show you. So that's it with my presentation. I'm over. If you have any questions, I'm ready to answer. Thank you very much.
Thank you very much indeed, Dr. Vinera. Despite all the modern drugs, we all have patients that we cannot really help any longer, either because the disease is too advanced or because of another reason, such as the resistance profile. So these are the patients for whom palliative care is pretty much the last option. So my suggestion is to watch a brief video about palliative care from Kyrgyzstan before we give the floor to Dr. Volod Abduvaliyev, Director of the Republican team.
Ağrıdım, ağrıganımı bilmezden kurortga vardım, sanatoriya vardım, oynayırardım, oynab muanisali yürürdüm. 35 yıl doktor bo'lib ishlab, o'zimni kasalimni bilmabman. Keyin reski Antalya, inegim tuberkulozga borib yozsam, tuberkuloz bukapili chiqibdi. 35 kiloga tushib ketdim. Unda meni ketadi dedi. Mana yashayapman. İşte bilan vaqti orasi 500 metrda, men o'rtada ikki joyda dam olib ishonaverdim. Adishga borib, jicha dam olib turib, yana borib turib, ishonada ishlab qaytib kelardim. Dinim opa, sizlar nimalar yordam berdi, men bularni berdi, 1 yil ichdim. 1 yil ichgandan keyin, nega sal uyda qarab bu o'qigandan keyin sal odam yo'qolib qolib, meni bormay qo'ydi doktorga. Hozir o 1 yil nimada yurdim, bulletinda yurdim. 1 yildan keyin sразу birinchi guruhga universitetga chiqardim. Hozirda ichiga borolmayman, tuvaletga zo'r bordim.
Ну, вот паллиативная программа тоже в какой-то мере стимулом является для больного тоже. И чем вот так оставить, тем более он медик, например. Если хоть не медик, но больного вот так просто оставить, лучше, чем вот так на паллиативное лечение, взять на паллиативное лечение и вот так понаблюдать, анализы там с ним поговорить. В какой-то мере он иногда ждет, говорит, хоть в месяц 1 раз приходите, говорит, ждет.
Yaxshilar muomala qilsa, enegim tuberkuloz emas, boshqa balobatlar kasallarni yaxshi bo'lib ketadi. Tuberkuloz deb turib, u odamni chekiga chiqarib qo'ysa, u bir yo'la o'ladi.
Кроме этого, у нас обязательно посещение не менее 1 раза в месяц этих пациентов. То есть мы, если они не просят нас приехать к ним посмотреть, мы сами к ним ездим 1 раз в месяц обязательно. Спрашиваем, видео, смотрим их состояние, там, жалобы, какие у них нужды. Иногда бывает достаточно того, что мы вот с ними общаемся, то есть им не хватает простого человеческого общения. Кроме того, все симптоматические лекарства, которые назначают им, помимо нас, например, другие специалисты или кардиолог, например, окулист, мы полностью покрываем их счета по этим лекарствам. Конечно, я думаю, это обязательно нужно, потому что после того, как у нас, например, выставляется исход неэффективное лечение, либо потерян для наблюдения, пациент как бы оказывается за бортом лечения. То есть и к ним не очень часто наведываются даже семейные врачи. Но в основном они нуждаются в поддержке, в социальной поддержке, в психологической поддержке. Зачастую достаточно бывает к ним поехать, где-то около часа с ними посидеть, поговорить, и они чувствуют себя нужными кому-то.
Good evening, dear colleagues. Good evening, dear members of the panel. It's evening in Kyrgyzstan already. We have started this morning, and prior to me, the speakers have been raising very important topics. This is the first day of the symposium, and you know, concluding this first day of the symposium with such a hard topic is probably difficult, but I suppose this is the way the organizers wanted it to be. So, no matter how difficult this topic is, we have to cover it. Palliative care in Kyrgyzstan is only beginning to make its first few steps. Back in 2014, the Minister of Health issued an order on the establishment of palliative care on the basis of the Kemin TB hospital. This was done back in January 2014, and for 4 years now, we have been trying to get up on our feet. As you know, it's very difficult to just make a few first baby steps. It's difficult to open up, but all these difficulties disregarding and notwithstanding, the decree was issued by the minister. On that basis, a regulation on the palliative hospital was developed, and it is on the basis of that regulation that we're still working. To put it in a nutshell, many of you probably know what palliative care is. So let me briefly tell you that palliative care is a set of measures aimed at improving the quality of life for terminally ill patients by providing medical, psychological, social, spiritual support for their patients and their family members. Well, this is the diagram of the World Health Organization. It resembles a tree, and they show us that this is the assistance to patients with diseases that threaten their lives and the lives of their family members. It can be given in homes, health centers, hospitals, and hospices. It improves quality of life. Palliative care provides benefits for healthcare systems by reducing unnecessary hospital admissions. It also relieves physical, psychosocial, and spiritual suffering. It can be done by many types of healthcare professionals and volunteers. The criteria of palliative care are as follows. Palliative care may be offered to all patients who have been through DOTS plus treatment for multi-drug resistant TB, for those that have been through XDR TB treatment but have not enjoyed any favorable outcomes. The same may be offered to those that reject treatment. This may be related to clinical state of the patient. It is also possible that an adequate treatment scheme may not be prescribed. And certain patients are suffering from social problems and economic problems. But those that refuse treatment, we should not refuse treatment to them. In our hospital, we've had a number of cases when people would receive palliative care, but having had the relevant conversation with them, we managed to persuade them that they could continue their treatment under the project, under the DOTS Plus program, and they're currently still in that program. I already told you about the fact that our hospital is the only hospital of its kind in our country that offers palliative care. The decision on offering palliative care is made by a concilium at the National TB Center, and we have developed a clinical guideline for palliative care. It was published in 2014. That means that for 4 years we've been following that guideline. But I think that maybe the time has come for it to be revised, for it to be amended, and I'm pretty sure the working group is probably thinking about that. It cannot be done overnight. So that was the picture of the hospital. So it used to be a TB hospital, and it is on the basis of this hospital that a TB palliative care hospital was established. In our hospital, we offer both medical services and non-medical services. Drugs are provided by the state through the mandatory health insurance fund. Also, medical services include laboratory services, clinical bacterioscopic services, X-ray, lungs, bones, and joints. We also provide counseling to the patients. That is done by narrow specialists from the territorial hospital, from the family medicine center. We engage ophthalmologists, endocrinologists, infectious disease specialists, psychiatrists, and we have a physician and an ENT doctor as staff members of our hospital. Other medical services include infection control. We have an infection control specialist. We have a relevant plan. We control personal protective equipment and medical products. Also, transport is available at the hospital. Non-medical services include the following. We have a social worker, in-house social worker. A lot of assistance is offered by the Ergine non-governmental foundation. They supply soap and detergents, wheelchairs, etc. Also, by talking to the patients and their family members, we also help them, and this is done by our social worker, by our nurses and doctors. Our hospital is also visited by religious clerics, by people from the churches, from the mosques. So over the 4 years, these are the results that we have been able to accomplish. The percentage of the deceased is pretty much the same. It's stable. So this is how many have been treated, how many have been discharged, and how many died. A bit too much, I think. Just as the previous speaker mentioned, we all have our problems. So far, we do not have a psychologist in our staff. The hospital is a 60-bed hospital. We have one social worker And it's quite difficult for that person to work in these circumstances. So beginning this year, we have one more staff, so we now have 2 social workers. Then we have insufficient support provided by healthcare workers. People simply burn out. Our staff members burn out because, you know, these are very difficult hospitals. These people see suffering of patients, patient deaths every day, and their salaries are low. Infection control, you know, we don't have any shielded lamps. We mostly use bactericidal lamps, simple bactericidal lamps. We don't have screened lamps. And as I mentioned, it's very boring in the rooms because it wasn't intended for palliative care. So the wards and the rooms are quite boring, and at the same time they're overcrowded. They should only have like they should only have like 1 patient per room, so as to avoid seeing the suffering of the other people. But we have between 2 and 3 persons per ward, per room. We still need ultrasound machine and an ECG machine. Problems that our patients are facing is the fact that there is no shop on the territory of the hospital, so they actually have to leave the territory of the hospital. The shops are nearby. There is no prayer room. And there is stigma from the surrounding population and from the healthcare professionals. The consultants that come to counsel, they are also part of this stigma. Ethical problems. Human rights are not violated in the hospital. This hospital has no uniformed security. Patients have the right to refuse hospitalization. Doctors and other specialists respect patients' freedom and autonomy, so the right to decide on their treatment belongs to them. They discuss care priorities and goals with the patients and their family members. They do not conceal information that the patients would like to know. And also the patient's wish to refuse treatment is their right. So I would like to conclude my presentation using the words of the great professor, the first doctor of the first hospice in St. Petersburg in Russia, Professor Gnezdilov, who said, "If you cannot cure a sick person, at least relieve their suffering. And if you cannot relieve it, share it with them." Thank you. Dear colleagues, the presentation part of our agenda is over. So now, please, your questions to the presenters, to the speakers.
Thank you for your excellent presentations. I'm Animesh. I'm working with MSF in Belarus, Minsk. I have a question for Jay regarding the presentation on diabetes comorbidity with TB patients. As you mentioned in your data that most of the deaths that you saw in the cohort were in the drug-sensitive group of patients, right? Majority of the patients who died, there was disproportionately high number of drug-sensitive patients who died compared to the other resistance patterns, if I'm not mistaken from the data.
I didn't actually present that. All I showed was the number in the total cohort that died. So out of 95 patients, 9 died.
And most of them were drug-sensitive?
Well, of the cohort, the majority were drug-sensitive patients, yes.
Okay. As we have seen from some of the studies, the rifampicin availability in diabetes patients is generally shown to be lower compared to non-diabetic patients. Could that be one of the reasons why these patients did not respond to TB treatment? Or is there more research needed to come to a guidance wherein diabetes patients should be getting a higher dose of rifampicin?
It's a really good question. So I didn't go into the drug-drug interactions related to diabetes and TB, but there's certainly interactions between rifampicin and some of the diabetic drugs, and probably also in the other direction. There is a broader discussion about what the right dose of rifampicin amongst drug-sensitive TB patients is, but that could be one of the potential reasons for this. Yeah.
Thank you. And a question for Professor Abdullayev. Congratulations for your presentation. I'm really speechless, though I'm talking now. I have been in so many regions and countries in the world, and I have never seen a presentation like this before on palliative care. So I feel really humbled by the work you are doing. The colleagues from Global Fund are not around, but someone made a question earlier today about value for money and cost. Everything cost, and then you need to make decisions. There is compelling evidence that transmission is the main driver of the epidemic of MDR-TB. Palliative care is difficult, so we can see even for making a question.
Even translation about palliative care become a problem. Huh?
But probably you can translate for Dr. Abdullayev. So my question is this. Transmission is the main driver of the epidemic. There is no need to discuss about it. The evidence is very clear, right? And in a hospital like this and in a population like the one described, where there is no chance to cut transmission through treatment, then ensuring proper infection control is a must. But what you describe is that you are making a lot of effort, but with little resources. Insufficient resources, not even for the caregivers. This is the kind of investment that I would like to see the Global Fund really providing full funding, because it adds a lot of value. It's cutting transmission in people who are source of transmission of a deadly form of MDR-TB. So I would like to understand what are the plans to ensure that this nice project in 5 years' time can be a state-of-the-art where resources are not a limit or an obstacle to ensuring zero transmission. Thank you.
Ну, как я сказал, что у нас вот в больнице вот она как бы не приспособлена для паллиативной помощи. Есть, я сказал, что скученность у нас в палатах. Ну, если мы привлечем инвесторов или глобальный фонд нам как поможет, мы можем построить на территории больницы соответствующую для оказания, специализированную для оказания паллиативной помощи такую больницу. У нас территория позволяет.
Дайте время для перевода, пожалуйста. Я переведу вас.
Хорошо.
As I said, the condition for in our hospital are not adapted for palliative care, but if we receive support from international donors, we could organize, we could build a separate ward with proper conditions.
На самом деле, доктор Эрнест, это действительно шикарный вопрос, и он действительно имеет огромное значение для общественного, огромное public health значение. Но мне кажется, что этот вопрос нужно адресовывать не сколько директору паллиативного госпиталя, сколько национальной программе целиком.
I think it's a great question and it has great significance for public health, but I think it should be directed not to the head of a TB hospital, but to the head of TB service as a whole. Нам нужен кто-то, кто ответит на этот вопрос. So do we need someone to answer this question too?
Да, уважаемые коллеги, но со стороны глобального фонда для противотуберкулезной программы на 3 года выделено 12 миллионов 110 тысяч долларов. На эти деньги, ну, недавно мы подали эту заявку в глобальный фонд. В основном эти деньги у нас заложено для приобретения противотуберкулезных препаратов на 3 года и на приобретение реагентов, расходных материалов для лабораторной службы. Но, к сожалению, да, действительно, данная больница, она для страны маленькая, Но у нас еще есть одна больница для оказания паллиативной помощи для южных регионов. Она находится в село Шакавтар, тоже рассчитана на 60 коек. Но для этой больницы 3 года тому назад выделено 5 миллионов сомов. И на эти деньги в этой больнице проведен хороший ремонт. Но, учитывая то, что там эти палаты не были рассчитаны на одного больного, но учитывая количество больных, мы будем это планировать для того, чтобы расширить коек для оказания паллиативной помощи. Конечно, это за счет средств глобального фонда не получится. Мы постараемся включить данную больницу перечень больниц, которые которым нужно ремонт, расширение коек. Пожалуйста.
So Global Fund has allocated 2,110,000 for this objective, and we applied for this amount to Global Fund. But the main part of grants is allocated for purchasing drugs, TB drugs, for 3 years, as well as reagents and consumables for our laboratory. But I should say that this hospital for our country is too small, and we have another hospital for palliative care in the south of the country, in Shekaftar village. It has 60 beds, and for 3 years ago, 5 million som, a local currency, was allocated for rehabilitation of this hospital. And we didn't consider how many patients we will have, so that's why the conditions are crowded, and we plan to expand the number of beds in the future. Of course, we cannot use WHO funding for this purpose, and we will try to include this hospital in the list of hospitals to be rehabilitated.
Коллеги, у нас, к сожалению, заканчивается время, и похоже, что караул устал, и техническая часть тоже. Поэтому, если вы не возражаете, последний вопрос на сегодня.
So we are running out of time, so last question for today, please.
Спасибо большое за обсуждение по паллиативной помощи. И мне бы хотелось все-таки отметить, что сегодня мы говорим о лечении пациента, ориентированном на человеке подходе. И когда мы говорим о паллиативной помощи, давайте не сужать его до уровня больницы, потому что все-таки большинство времени эти пациенты проводят не в этой паллиативной больнице, но дома. И, наверное, вот так же, как и другим пациентам, которым...
Thank you for bringing up the topic of palliative care. And I would like to highlight that speaking about patient-centered approach, we should not only speak about palliative care. So let's not limit ourselves with this topic, because patients spend their time not only in hospitals, but they spend a lot of their time at home.
И паллиативная помощь не подразумевает дорогих затрат как таковых. Ее можно оказать в амбулаторных, то есть на уровне вот, у пациента на дому, и каким-то образом улучшить инфекционный контроль дома, и, наверное, это будет целью.
И, наверное, не только улучшить инфекционный контроль, но и как-то назначить препараты для облегчения его физического состояния.
Конечно.
We need to keep in mind as well that palliative care is not expensive. It can be done in ambulatory conditions and at home. And our objective in this case would be to improve infection control conditions as well as providing palliative drugs as symptomatic care.
Ну, наверное, на сегодня все. И если вы не возражаете, я предоставлю слово Игорю Кильчевскому, директору Восточноевропейской и Среднеазиатской сети людей, живущих с ВИЧ, для такого рапапа последней сессии.
Я прошу прощения, я очень коротко скажу. Меня зовут Игорь Кильчевский, я на данный момент являюсь как менеджером этого большой сети региональной. И, наверное, я должен был бы сказать, что предложить, давайте создадим некоторый пул такой всех организаций, всех наших финансов, глобального фонда там, и других финансовых потоков, которые есть в нашем регионе. Создадим, может быть, ССМ, который занимается одновременно и туберкулезом, и малярией. Посмотрим на те сегодняшние сочетанные болезни, которые были сегодня перечислены во время последней сессии. Значит, и я так смотрю, что от ВИЧ у людей с ВИЧ-инфекцией развивается диабет. Люди с ВИЧ-инфекцией больше предрасположены к заболеванию туберкулеза. У ВИЧ-инфицированных, как правило, есть гепатит. Это не значит, что нужно сделать только одну какую-то организацию. Просто можно, наверное, всем объединиться и более эффективно все это делать. С своей стороны хочу сказать, что мы будем подавать заявку на новый значит, объявленный глобальным фондом тендер совместно с ТБ-рэпом. Да, это будут разные две заявки, но мы план нашей работы будем выверять прямо пошагово. Ну так, в завершение, просто за время, паллиатив это хорошо, но паллиативом мы занимаемся прямо сейчас, здесь с вами. Мы хорошо друг к другу относимся. Столько добрый глаз, что я буду жить еще, наверное, вот я 25 лет почти живу с ВИЧ, но минимум еще 25 я вам обещаю проживу. И буду оказывать вам поддержку обязательно. А вы мне спасибо.
Let me introduce myself. I'm a program manager for a big regional network.
Сеть чего? Подскажите, пожалуйста.
People living with HIV. Региональная сеть Восточноевропейское Центральноазиатское объединение людей, живущих с ВИЧ-СПИДом.
So the Union for Central Europe and Central Asia for people living with HIV/AIDS. So I would like to say that it is important for us to create a regional organization to organize our financial flow regionally. And it is important to consider the problems of TB, malaria, and comorbidities. I can see that many people with HIV develop diabetes. They're more prone to TB, and many of them have Hep C. And it shouldn't be done with the means of only one organization. We need to become more efficient. I should also add that we plan to apply for a new tender together with TB-Rep. The applications will be submitted separately, but we will agree our steps. I would like to reiterate the importance of palliative care, and I promise you that after having lived 25 years with HIV, I plan to live 25 more, and I promise you to continue my support.
Уважаемые коллеги, на сегодня это все. Я думаю, что у нас у всех был очень тяжелый, но очень интересный день. Каждый из нас, я надеюсь, что-то из этого дня вынес в зависимости от своих интересов, убеждений, верований. Честно говоря, я даже не знаю, что было для меня наиболее интересной презентацией. Спасибо вам большое и увидимся завтра.